Awesome. Okay, we are live. Hello, everybody. It's Dr. Earle here, and it's Hump Day with Dr. Earle. This is the time I get to see you guys and answer all your plastic surgery questions. And today we are going to talk about breast surgery. All right. So every single day we get questions regarding breast surgery. Anywhere from what's the best surgery for me? What should I do? I want to achieve this look. How do I know if I need a breast lift or just a breast augmentation? Do I need a breast reduction? How do I know if I need a lift with or without an implant, etc., 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 right? So every day, multiple questions about the breast, because honestly, it is a little bit complicated, and that's why we go through many, many years of school and training in order to do this, right? I went through 17 years of education and training after high school in order to be able to do this, and of course, and now I have over 10 years of experience, and there's not thousands of cases under my belt. Okay, so breast surgery, all right? So where do we start, right? So you know that you want to improve your breasts, okay? And it can be for whatever reason. You can be a young patient who just wants a bit more volume, or you can be someone who's been a mother, been through pregnancy once or twice, multiple pregnancies, and the breasts are now, drooping, and you've lost a lot of volume. Or perhaps you're someone who went through weight fluctuations or massive weight loss. You started taking, say, for example, Ozempic or Mounjaro. You lost a ton of weight, and now the breasts are now drooping, and again, you've lost a ton of volume there as well. And then last but not least, you could be someone who just has very, very large breasts. You're suffering from back pain and neck strain, and it's really affecting your life and pretty much every single day. And so you may want to do a breast reduction, which is actually one of the surgeries I think that has the highest satisfaction rates of about everything that we do, because patients end up feeling just so much better after the breast reduction. Okay, so that is the first thing in terms of our algorithm, our decision tree, is whether you're going to need a breast aug, a breast lift, or a breast reduction. Okay, and so breast reduction versus breast aug is kind of straightforward, right? You want more or you want less, right? Pretty easy. Okay, I want more. Okay, great. Okay, so you want more, you're going to be in this category here. Now, here's the next question. Where is your nipple position and how tight is the skin? All right. So if you have no droopiness, what we call basically no ptosis, which is the technical term. The technical term for droopiness is ptosis, okay? So if you have no ptosis, meaning that the nipple position is above your inframammary fold, then that means that you are a candidate for a breast augmentation and that you don't need a lift, okay? So basically, your skin is fairly tight, the nipple position is where it's supposed to be, right in the front of the breast, and it's certainly above the inframammary fold, okay? All right, so if you have all that going for you and you just want some extra volume, then breast augmentation is the surgery for you, okay? Now, what about you want more volume, but the nipple position is not above the inframammary fold, it's somewhere like at the inframammary fold or below the inframammary fold. Well, in case then you're probably going to need a breast lift, which you can potentially combine with an implant, okay? But whether you need a breast lift or not, that all depends on the nipple position in relation to the inframammary fold. You're looking at the breast from the side, okay? So if this is the line of the inframammary fold and the breast sits on top with the nipple here, well, that's where you are doing the breast augmentation. Now, if the breast is starting to droop and the nipple position is at the inframammary fold, then you are going to need a lift, but maybe it's not a major lift. Maybe you can do just what we call a circumareolar or a donut lift. Now, if the breast continues to drop and then now the nipple is here below the inframammary fold, then you're certainly more of a lift, which can be either a vertical or lollipop lift, or potentially an anchor lift, okay? And then last but not least, if you really have a lot of droop and the nipple position is at the lowest point of the breast, okay, that's grade ptosis. That's the most kind of severe amount of ptosis or droopiness. Then for sure, for this one, you're definitely looking at that anchor type scope pattern for the lift, okay? So, again, the next decision point, if you want more volume, is whether you're going to need a lift And that's all going to depend on your nipple position in relation to your inframammary fold. Okay? And then last, of course, if you want less volume, then we're talking breast reduction, right? That's pretty obvious. So the one thing that you want to keep in mind though is that all breast reductions, by definition, also carry a breast lift. Okay? Because for the most part, it's extremely rare to have a breast reduction, to have your nipple position above the inframammary fold. You almost never see that, okay? So by definition, if you're having a breast reduction, you are going to have a lift as well, and that just goes together. It's not like something you have to ask for. It's basically part of the same procedure, because the surgery that we do for a breast lift and the surgery that we do for a breast reduction is very, very similar. It really all depends on how much actual breast tissue we are removing at the time of surgery. So we're doing strictly a breast lift. We're not going to be removing almost any mass or breast tissue. We're just going to be removing mostly loose skin. If we're doing a breast reduction, we are going to be removing not only the loose skin, but also a significant amount of volume of breast tissue or mass in order to reduce the breast altogether and for the breast to weigh less, so that you have less back pain and shoulder pain and neck strain. Okay? All right. So now we've got this, the type of lift we can talk about is going to depend on the degree of droopiness, okay? And honestly, for the donut lift, we can only raise the nipple position about 1 to 3 centimeters, so not very much. So not a lot of people really get this. The vertical or lollipop lift, that's the one where you have the scar goes around and then straight down, kind of like that, okay? And then of course anchors where the scar goes around, straight down, and then underneath. Okay, that's the vertical and that's the anchor. The vertical is for like maybe grade 1 to 2 droopiness, and then of course between grade 2 and 3 droopiness, you're going to need that anchor type pattern. Okay. All right. So now we've decided that. So what's the next thing we're going to decide? Well, all right. So I know I need a lift. Now what I don't know is whether I need an implant or not. All right. So that's the next decision point. And so that's going to depend on several factors. One is going to be what volume do you actually have? So how much breast mass or volume do you have? And are you happy with that? So now forget about like where the nipple position is, forget about the droopiness. Just say for example where you wear a bra and you kind of lift everything up with the bra, are you happy with the amount of volume that you have? And if you're happy with the amount of volume that you have, then you don't need an implant. We can do a breast lift without an implant, okay? However, if you do that and things are still feeling pretty empty, say for example you're a massive weight loss patient, you lost 50 plus pounds and things are looking like you have empty breast syndrome, or like things are looking very, very empty, then yes, you do want to add an implant to that lift, okay? And then it's also about the look. Say like, yeah, I mean you have some volume, maybe you're like a B cup, you have that droopiness and you're like, hey doc, I would really love to be in a full C cup. And then in that case, we can then again add the implant to the lift. Okay? All right. So those are the 4 options: breast aug, breast lift with or without implants, and breast reduction. All right. So now for the breast aug and the breast lift with the implant, then the decision point is going to be the implant itself, right? So hey doc, what implant should I get? What size should I get? What profile should I get, right? What brand should I get? Okay. So talking about the brand, right here at Pure Plastic Surgery, we have 2 brands that we use. One is called Earle, and one is called Motiva, okay? They're both excellent brands, and what's the difference there? Well, the Motiva implant is a newer implant here in the US, so not a lot of experience in the United States, but it has been used for quite a few years, about 10, 12 years in Europe and in South America. And people really, really like it there because the gel is like a softer gel. It's a really, really natural feel. And also the Motiva implants are very highly cohesive, so like super gummy, if you talk about gummy bear type implants. And so it really kind of holds its fullness in the upper pole, and it has a very, very little chance of rippling. When you see like little wavy patterns sometimes in implants in very thin patients, especially in that upper pole or cleavage area. So the Motiva implants are doing very, very well. Lots of upside to Motiva. Downsides are they're more expensive, right? Just like everything else, right? So they do cost more. The Earle implants are great, very solid implants, fifth generation implants, been around a long time, excellent safety profile, low capsular contracture rates, okay? And they're gonna be a little bit less expensive than the Motiva implants, all right? Okay, so those are the brands, the two brands that we have to offer. What about the profile? Okay, so profile, you may have heard of this, is how far the implant kind of sticks out, okay? So this one here, it's a little bit flatter in this direction, it has a wider base. This is what we call a moderate profile implant, okay? This is for a more natural look. And then this here, this is going to be what we call a full or high profile implant. So it comes up a bit more. That's going to give you more fullness in that upper pole, a little bit less of a natural transition from the chest into the breast area, okay? And then of course you have your extra high or extra full implant. This is for like that bold look, right? So you really want like things to really kind of, you know, stick out. Then you're gonna go for that extra full profile, okay? So honestly, the most common ones that I use here at pure plastic surgery are typically your moderate profile, and then the second most common will be the full profile. We don't use the extra full profile so much anymore, but that really, of course, depends on the patient and the type of look that they're going for, all right? But nowadays, 25, people are going for a little bit more, just in general, just in plastic surgery in general, we're seeing people going for more enhanced natural looks, so we're using a lot of the moderate profile implants, or we're doing a lot of lifts without an implant at all. And that's doing a lot right now as well, as also people actually removing their implants and then doing a lift, which is also a possibility, okay? And then, so now you're going to choose a profile. So you want a more natural look, you're going to go for that moderate profile. So you really love those Motiva implants. That sounds really cool. So you're going to go with a Motiva moderate implant. But then the last part of it is what size are we going to get? And that's going to depend on two factors. Once again, it's going to depend on the look that you're going for, but also your specific objective measurements, right? If you're a petite 4'11" woman, I'm not going to be able to put 800 cc implants in you, okay? No matter how much you ask for it, it's just going to look ridiculous and it's not going to fit in your body, and you're not going to be able to move, okay? So yes, your anatomy and your measurements, okay, matter a lot into what implants we're going to actually be able to use, okay? And that's sometimes, like I said, not really up to you, not really up to the surgeon. There are certain implants that are going to fit within your body, within your chest, and certain implants that just will not fit and it doesn't make any sense. Okay, so yeah, we do take measurements and we kind of combine the measurements along with your goals and your desire. We can put all that together so that we can then choose the best implant for you. Okay, all right. So that pretty much narrows it down. All right. So I am happy to take any questions regarding breast surgery or anything else in plastic surgery.
What are the options after a failed breast lift plus capsulorrhaphy?
The options after a failed breast lift with a capsulorrhaphy. Okay, let's explain that a little bit. So, first of all, what's a capsulorrhaphy? Capsulorrhaphy is when you're tightening up the pocket where the implant is placed. Okay, so sometimes, especially if you've had implants for many, many years, or perhaps the implant that was placed did not really correlate with your size or with your measurements, and too big of an implant was placed. Sometimes that implant starts to kind of migrate off the sides and get down into your armpit area. And so then if you're going to go to and exchange that implant and potentially do a lift at that time, you have to then fix the pocket. And when you fix the pocket along the sides here, closing down that pocket, that's called a capsulorrhaphy. And you can do that either thermally with heat, or you can do that with stitches or sutures, okay? Now, the option, if you've tried to do that and the implant falls back once again, there's a couple options, and of course every patient's a little bit different, but one option is to change the pocket. So say, for example, you had a submuscular implant. Well, now you're gonna put the muscle back down and you're gonna create a new pocket above the muscle, and what I like to call, and what I like to use, which is the subfascial plane, which is a new plane that we're using nowadays. It's not the same as the subglandular plane that we're using many, many years ago. This is a new technique that not all surgeons do, but we do it here at plastic surgery, and it's a great area to place the implant. So you can do a pocket change, and or you can add a mesh. So that's something that we didn't talk about here, which is the mesh. I'm sure people have heard about mesh or internal bra. So is that it's literally a mesh that you're putting inside the pocket to hold the implant in place, okay? And that mesh can be made of multiple different materials, but for the most part we like to use a biologic mesh, meaning that it's a mesh that it eventually will get incorporated into your body, okay? And therefore your body basically absorbs the mesh, and so the tissues just get reinforced in that area. So those are the two things that you can do to fix that problem.
Can you perform a breast aug with an upper eyelid surgery?
Yeah, definitely. So there's many things you can combine the breast augmentation with. The most common thing here for us is a tummy tuck. So we call that a mommy makeover. So you can combine a breast aug with a tummy tuck. You can combine it with the upper eyelid or blepharoplasty surgery. You can combine it with almost anything really. You can combine it with a lipo 180 or a lipo 360. We call that the Miami makeover. So there's different things that you can combine it with.
Can you provide a little breast lift for a B cup where you have no skin to remove, and can you do no anchor?
No.
Not sure I understand that.
Yeah, because if you have no skin to remove, then you probably don't need a breast lift, okay? Typically, if the nipple position is below the inframammary fold, then there is skin to remove, okay? If you're up here, there's really, if your nipple position is already above the inframammary fold, it's very tough to try to lift that up even further, okay? So if there's no skin to remove and you have a small breast and the nipple position is already above the inframammary fold, then you probably don't qualify for a lift.
All right, so we'll take the Instagram stories after this last TikTok question. I'm about to get my breast aug done on the 11th. I'm guessing June 11th.
Yeah.
When would you recommend stop smoking?
So you gotta stop smoking 30 days before your breast aug or really any procedure, okay? So we recommend that all of our patients stop smoking at least 30 days before, and not only smoking, basically any way of taking in nicotine. So no nicotine at all for 30 days before, whether it's through smoking, vaping, gum, patches, whatever way you're getting nicotine, you gotta stop it 30 days before surgery.
Will you prescribe a muscle relaxer for breast reduction / lift with implants?
I typically don't. I don't feel like my patients need it. It would be extremely rare that someone actually needs that. Most patients with the breast surgery, even with an implant, they do really, really well. And there's minimal pain. Like they barely have to take the Percocet. I mean, maybe they'll take it the first day or the first night, and that's it.
My doctor el mejor.
Hey, muchas gracias. Thanks for the shout out.
Next one's a question.
Okay.
Can a BBL, tummy tuck, and breast lift all be done at the same time?
I wouldn't combine all those things, no. I think that is way too much surgery. I think the risk of complications goes up where you're combining all of that. So you're combining a tummy tuck, a breast, and a BBL. That's basically combining a mommy makeover and a BBL, two big surgeries in one. And so the risk for bleeding and needing blood transfusions goes up. Risk for infection goes up, but more importantly, like really scary stuff, the risk for blood clots in your legs or in your lungs, which could potentially put you in the hospital or worse, potentially death, goes way up when you combine all those procedures. So I do not recommend that, whether it's here with me in Florida, in the US, or any other country. I know there's countries out there like Colombia and the Dominican Republic, they claim to do it all the time, even Mexico. I do not recommend that. I do not recommend that. There's so many disasters I've seen from combining all those surgeries. Please just don't do it. My recommendation is to do your mommy makeover, so basically the breast surgery and the tummy tuck first, and then come back 3 months later, do your lipo 360 BBL.
I'm not sure if you've received this question before, but can you fix cauliflower ear?
That's not something that I do. I'm basically a body guy, so from here down, I do some stuff, and then that's it. But can it be fixed? Yes, cauliflower ear can be fixed. Okay, so you just have to go to a plastic surgeon that specializes in that, possibly a facial plastic surgeon, and they can certainly make the ear look a lot better and fix that for you.
All right, this is a perfect question given your experience in breast reconstruction. How hard is it to reconstruct 10 years after double mastectomy? I've tried 4 different times.
Oh boy. All right. So that's also depends on many factors. I really have to do like a full evaluation to see exactly what's going on. For example, maybe you had a double mastectomy, maybe you had radiation, right? So radiation is a huge factor into like what type of reconstruction you can have. But not knowing anything else, someone who's had multiple attempts at reconstruction after a mastectomy, a lot of times it's because they've had radiation and you're trying to put an implant in that area, and a lot of times it doesn't work. So what I would typically recommend for those patients is a tissue reconstruction, which you do that with a very complex surgery called deep flap or free flap, and that's something that needs to be done in the hospital setting. So it wouldn't be something we do here at Pure, but certainly I have a lot of colleagues that are excellent in that procedure that if you're here in Miami or Florida, we could recommend.
Yes, she says yes. She's had radiation and always had an infection.
Yes. So I would recommend a tissue reconstruction, probably a deep flap. And if you're in Florida, I recommend the Miami Cancer Institute with a good buddy of mine. His name is Miguel.
Thank you. If I get a subfascial breast dog, will I have high risk of capsular contraction?
No. So that's a great question, and the answer is no. So subfascial is the New York that I was talking about. So back in the day, say 10 years ago, there was only two options, right? It was called subglandular, so just beneath the breast, over the muscle, or submuscular. Those were the two options, subglandular, submuscular. Now the third option, it's kind of in between. It's called the subfascial approach. The subfascial approach is also above the muscle, but it's in a plane that's in between a thick layer that covers the muscle called the fascia. And we can get in between the muscle and the fascia, create a pocket in that layer, and that's where we can place the implant. And the great thing about the subfascial plane is that it's the best of all worlds. You still have very, very low capsular contracture, I'm talking 1%, okay? And also at the same time, you don't have what's called an animation deformity, meaning that when you move around, when you do certain movements, when the implant kind of bounces around or moves around. You see that when you place it beneath the muscle. So that's why the subfascial plane is my preferred plane for breast augmentations. Almost all of my breast dogs I do in that subfascial plane because I think you preserve the muscle, you're not destroying the muscle at all. The muscle is where it's supposed to be, and you have, but at the same, so no animation deformity, and at the same time you have the really, really low capsular contracture rates.
Can alloclay be used to add volume to upper back, or is it just for spot treatment?
No, it can be used for volume, but having said that, don't think of it like it can replace like a full BBL, right? It's not going to replace a full-on BBL. But it can be used to add a bit more volume in certain areas, that you need it. Say, for example, the upper buttock, maybe just a little bit more in the central buttock to round it out just a bit. Or the hip dips. Sometimes, say, you had a BBL, your hips were looking fantastic, day one, and then, you lost some of the fat there, and you just want to add a little bit more back. Well, that's a great example where you could use alloclay as well.
Can you speak about nipple reduction on a patient who already has an implant?
Yeah, nipple reduction, whether you have an implant or not, shouldn't really be an issue. So you can certainly do it, no problem. And that's surgery that can be fairly straightforward. If that's all you're doing, you're not combining it with anything else, a lot of times it can just be done under local anesthetic, very quickly, kind of in and out type of surgery with no downtime.
I'm 6 months post-op. I'm 5'3", I have 350 cc's under the muscle. Unfortunately, my capsulorrhaphy did not hold up. Previous surgeon recommended stitching the muscle up into my rib cage. Do you have an opinion on this?
Right, so that's what I was talking about before, where there's two options there. One is to just go ahead and switch the pocket. So I think that's kind of what he's referring to. He's like, okay, right now they're beneath the muscle. Let's do this. Let's create a pocket above the muscle, but we don't want that muscle just kind of floating around. So we can tack the muscle down. In this case, he said to the rib cage. I don't know that you actually have to put it into the rib cage, but you can tack that down, create a pocket above it, and now you have a new stable pocket for the implant.
Do I have an opportunity to stay in the clinic one day after post-op?
No. So the type of surgery that we do here is what we call office-based outpatient surgery. Okay, so that means that it is all ambulatory surgery. Ambulatory surgery means that you go home. Okay, so you cannot stay in this facility overnight.
What kind of anesthesia do you use, and how do patients feel after?
So I use general anesthesia for pretty much almost all of the procedures that we do here, okay? Whether that's the breast procedure like we're talking about here today, tummy tuck, liposuction, BBL, pretty much for all of or most of our procedures, I use general anesthesia. And I think it's actually the best way to go and the safest way to go. Okay, because you totally eliminate the risk of what's called lidocaine toxicity. Lidocaine is a medication that you have to give someone to numb them up in order to be able to do a procedure when they're awake. And if you give someone too much lidocaine, they can get toxic and they can have seizures or a heart attack and potentially die. And I just like to eliminate risk, because you all know safety is my number one concern. So I remove the lidocaine altogether. I do everything in anesthesia, extremely safe. And how do patients feel? They wake up. Of course, you're going to be a little bit groggy. Maybe the memory's not working so great initially, but you're going to be in a recovery room. You're going to be there for an hour. And when you're feeling better, awake, and we'll call your family members to come pick you up.
Okay, real quick, what's the minimum BMI for a skinny BBL?
So for most patients, it's going to be a BMI of 20 as the minimum BMI for a skinny BBL. I have seen some patients that are BMI of 19 and they've had enough fat because they didn't want to make a huge change. They just wanted very subtle changes. So that's a possibility. But for the most part, you need to be BMI 20 or above.
Can you do tummy tuck, breast reduction / lift together if you have sickle cell trait 49.8?
Sickle cell traits? Okay. So yeah, typically if you have sickle cell trait, then you are okay, and we can do that combination with like a mommy makeover, but yes, your breast surgery and your tummy tuck, okay? If you have sickle cell disease, then you're not a candidate for doing this procedure in the office-based outpatient surgery setting like we have here, okay?
I have my surgery with Dr. Earle in July. When the implant election will be made?
When will it be made? It's going to be made on your pre-op day, okay? So, a lot of my patients, they come from out of town. We're very blessed. Most of our patients come from different states, different countries. People from all over the world are coming here. And so when do we choose the implants? We're going to choose them on pre-op day, which is the day before surgery. And why is that? Why can't we choose it before that? Because, what did I say? Remember when I talked about size and I had to take some measurements, right? I have to be able to take those very objective measurements to then combine that with your desires and see what's going to be the best implant for you.
Thank you. Do you still recommend Silogen for scar treatment?
Definitely. I think it's one of the best products out there for scar treatment. I recommend all my patients start using it at 2 weeks post-op, twice a day for at least 3 months.
If I come to Florida for a mommy makeover, how many days should I plan to stay for recovery and follow-up?
Yeah, you should plan to be here at least 7 days total. So you're going to have your pre-op day, your surgery day, and a minimum of 5 days post-op, okay? So that's the absolute minimum. Of course, you can stay longer if you like, but no less than 5 days. In fact, if anyone leaves here before the 5 days, they are leaving what we call AMA, against medical advice.
Thank you. If I change my moderate profile implant to a high profile implant of the same size, will there be a difference? Do you recommend it?
There will be a difference because the implants are different, right? So, but I usually don't recommend changing it to the same size, right? If the issue is that you're not happy with your moderate profile implant because you don't have enough upper pole fullness, then yeah, definitely go ahead and switch to a high or full profile implant, but you probably want to go up in size as well. So say you have like just an example, you have a 375 moderate implant, you don't have enough oomph up here that you feel like you want to have more fullness per pole, more defined cleavage, then yeah, by all means, change to a high profile or a full profile implant, but you should go at least 100 cc's higher. So you're going to want to change to, like, say, a 475 or 485 cc implant to really get the noticeable difference there.
Thank you. Let's see, going to some TikTok questions.
Ooh, I love TikTok questions.
Do you have thoughts on Motiva implants?
I have very good thoughts on Motiva implants.
Share those thoughts.
Yes, so Motiva is quote unquote the new kid on the block here in the US, but it's not the new kid out there. Okay, so Motiva has been around for at least a decade, 10 to 12 years in Europe and in South America. But it just got recent. The reason we're talking about it now and that we're using it now here in the US is because it recently got its FDA approval here in the United States. Okay, it is what's called now a 6th generation implant. Basically, your next generation of implant. It is a great implant. It is very cohesive. So you may have heard the term gummy bear type implant. So this is like the gummiest of gummy bear type implants, basically. And so the silicone that's inside the implant, it completely fills the implant, 100% fill basically. And so the implants end up giving you a little bit more projection, a little bit more fullness in the upper pole. They also have less what we call rippling, okay, like the waviness of it. So you see less rippling with them. And then it has this very fine, super fine texturization, which basically allows it to have one of the lowest capsular contracture rates we've ever seen in an implant. And that's even if it's placed in that subfascial plane that we talked about. So they feel super natural, so I do highly recommend them. The only thing, like I said before, they're going to be more expensive. Okay, that's the one thing that you gotta know.
All right, we're at 30 minutes.
Okay, awesome. I like that today because we got a nice mix of questions from TikTok and Instagram, which is great. I love seeing like our TikTok followers are now getting more engaged and asking questions, so that's awesome. Thank you guys. And so remember, we do this pretty much every Wednesday, somewhere around 4:30 p.m. All right. So I look forward to seeing you all next week on Hump Day with Dr. Alex Earle. I'll see you then.